Hello everybody, and welcome to this, your first podcast for Clinical Placement 3 on what I have to say is an absolutely gorgeous Friday morning here in Middlesbrough. I'm coming to you from almost the top of the tower, not quite, floor number 7, and I'm not entirely sure whether or not you're going to be able to see this, but I'm going to do it anyway, with some actually spectacular views of the Cleveland Hills there. And I think if I can just, yeah, you can just about make out Rosebery Topping. In the distance. But unfortunately, because we're so high up, I'm absolutely roasting in here. Roasting. Anyway, welcome. Excuse me. So, as you probably saw there, your opening sequence for my first clinical podcast of this particular placement was Teleaddicts, a rather quaint TV quiz show from the late 80s, early 90s, sort of when I was around sort of the age of around 7 to 10. Great TV show. Noel Edmonds, as you're aware, an absolute legend in that particular period. Probably not so much now. So, you've had 4 weeks out in clinical placement. I hope everything's going well. It didn't take you too long to get back into your stride. Couple of sort of news features from here at the university. Obviously we've had the exam boards, and as far as I was aware, everybody is passed and things like that, so congratulations to you all. What else has been happening? This week was UKRC, the UK Radiological Congress. Caleb was giving a presentation there around the SPICE system and how it's worked with our first years, which was all very good. Went down quite well. And also myself and Peter were giving a presentation around podcasts. So you've experienced two things within this module that we've delivered presentations on, which I think is quite neat. Unfortunately, Peter was unwell. Those of you who follow him on Twitter probably saw how unwell he was. Unfortunately, he had something called a Quincy, which isn't an allusion to a 70s pathologist in the United States who lived on a yacht, bizarrely, but a peritonsillar abscess, which is a kind of complication of tonsillitis. But I've been to see Peter on Wednesday after UKRC to give him the lowdown on how the presentation went, and he's doing quite well. He's really coming along, so that's great. So obviously our thoughts go out to Peter. So I promised you 4 podcasts. This is the first of those. I know I said I was going to do them around different themes, and this is going to be around paediatrics. This is still definitely the theme of this particular podcast, but I may be changing the other themes a little bit later on. But we'll see how that goes. But this, as I say, this is going to be about paediatrics. So, what am I going to cover in this particular podcast? Well, not necessarily within the podcast, but certainly the supplementary learning materials that are out there on Blackboard. We're going to be looking at paediatric anatomy and how that differs from the anatomy for adults. We're also going to be taking a little look at consent and confidentiality around paediatrics. I've also got some stuff in there around Gillick competence, what constitutes Gillick competence and what Gillick competence can actually be used for. And also, again, because of some of the research that we've been undertaking within the university, you're probably aware of the paper that I want to discuss within the wiki, but it's Tom Warlow, Peter Walker-Birch and Phil Cosson's paper around whether or not we should be using paediatric gonad protection, and also whether or not this is being employed within your department. So without further ado, let's get cracking. Paediatric podcast. Okay guys, so the first task for the week is a little bit of revision around paediatric hip disorders. There are 4 wikis on the Blackboard site for you to contribute to, and there are a few things that I'd like you to do with them really. Have a think about the definition of the disease, basically what it is, and what would happen if it wasn't, treated, those sorts of things. Have a little think about the actual imaging modalities that are used, and also if projection radiography is used, a little bit of information about techniques, hints, tips, tricks, things that you've seen in clinical practice. So it's not all just about you kind of researching these four different pathologies, but they are on the Blackboard site. So go in there, have a look at them. Okay, so this is the this is where the wikis are going to be located. So just so that you're aware, so if you look across the top here, we've got the Learning Materials tab, then Placement Learning Materials, then the Paediatrics. This will be a little bit fuller, obviously populated with the podcast and the other things that would be useful for you to do. So then if you go into Paediatric Pathologies, just located there, go into there, and then it'll bring up the wiki page. Excuse me. Now, if you wanted to contribute not to chronic hip dysplasia, but say to Perthes pages, then that obviously shows you where it is. Now, if you do come into contact with an interest in pathology in practice or an interest in technique that you want to share on a separate page, feel free to do that. Just click on the new page and then it'll bring it up for you. Anything that you put in here obviously should be referenced and all the rest of it for us. So that would be great. So if you can contribute to this, I would expect everybody to contribute at least one thing to it, or contribute in at least to either, slip up Sufi, Perthes, whatever. But please do contribute to it, and sharing knowledge, is really, really useful. So now I've got the wikis and everything out of the way. What I wanted to briefly talk to you about is kind of consent and consent for children. I mentioned earlier on about the Gillick and Fraser competence. What I usually do with our third year students is kind of go through the UN Convention on the Rights of the Child, parental rights and those sorts of things, but they're fairly kind of self-explanatory, and I've put together a modified kind of document for you all anyway on Blackboard that you can read through at your leisure. I don't think there's any real benefit from me kind of discussing through it. But what I did want to talk to you about a little bit was consent. Now I know that you've covered consent previously, so you know that there's the kind of different types of consent: written, verbal. The three things that make consent viable. So that it has to be given voluntarily and those sorts of things. And you've probably covered it in research methods as well. So again, I don't want to dwell too long on that, but I do want to discuss a little bit about Gillick competence. But before we sort of dive straight into Gillick competence, I just want to ask you two questions, really. The first question: in UK law, who is classed as a child? And the second question will be, at what age can you leave a child at home on their own? Okay, so a couple of things that we need to be aware of around Gillick competence. Remember that Gillick competence only really refers to the understanding of the information stage of the procedure. Okay, so the other two facets of consent, namely the giving of the information and that consent has to be voluntary, still need to be met for patients to be Gillick competent. So, and another odd thing around Gillick competence as well is that it only means that a child can consent to an examination. The child can't consent not to have treatment, so it's a little bit odd in that respect. Now, there are a couple of sort of good practice guidance things, if you like, around how to proceed if you think a child is Gillick competent. You should always try and involve the parent or guardian, and that should only really be done with the child's consent as well. Other things that you might think about doing as well are really looking at the actual situation, because remember that the child might have the ability to consent for some examinations, but not for others. And also, you should always be trying to act within the best interests of the child. Having said that a child can only consent to having an examination, they can't consent not to have an intervention. The Children's Act states that if a child refuses treatment, then they cannot be examined, even if they are deemed competent, if they refuse. Which sort of makes sense, really. I mean, we've all been, and you will be, if you haven't already, in the situation where no matter what you're trying to do with a child, they will never kind of comply and consent to having a radiographic examination. And at that point, the reality is that you've just kind of got to step back and say, you know, we'll have to postpone this or do it at another time.